A 42-year-old man, a 42-year-old man is brought to the emergency department because of 6-hour history of moderate diffuse headache, blurred vision, difficulty concentrating, moderate back pain, tingling of the hands and the feet. He made 3 dives during 4 hours to depth of 90 feet. His symptoms um, his symptoms begin while he returned to the dock after 4 hours in the water. He has no history of serious illness, takes no medication. He has smoked 1 pack of cigarettes daily for 20 years and drinks 4 to 6 12 hours beers daily. His pulse is 100 per minute. Physically, no neurological cranial intact, muscle strength 5 by 5, and upper lower extremity 4 by 5, deep tendon 1 plus in the upper extremity, deep tendon 1 plus in the upper extremity, and 3 plus in the lower extremity. Babinski sign is present bilaterally. Sensation is normal over hands. Proprioception, vibration, temperature are decreased over the lower extremity. Cognition is intact. Which of the following is the most appropriate next step in the management? What is your diagnosis?
Isn't that the thing with the when you go, how you call it, the sickness when you go out under the water?
Decompression sickness.
Yeah, yeah, that one. Sorry,
Okay,
that one.
let's
I
see.
mean, I think that's the only. Every time I see you, they went deep into the water. I always think that one first. I don't know. Don't blame
Okay,
that.
it is good.
Okay, good. Feel like it's always the same question. Somebody went into the water deep down and came back up really quick. It's the same one. These patient symptoms are consistent with a compression sickness that can occur. Then they're going to change it on the exam. That can occur in a variety of situations in which the body undergoes a decrease in atmospheric pressure, but is most frequently encountered in divers using a self-contained underwater breathing apparatus like a scuba. Scuba divers typically breathe compressed air, which is composed of nitrogen. The role of the other compressed breathing gases, for example, helium is beyond. Okay. The solubility of a dissolved gas in liquid is directly dependent on the partial pressure of the gas. For this reason, blood and other human tissues will accumulate dissolved nitrogen when the body is exposed to greater atmospheric pressure. Excessively rapid ascent can lead to a sudden decrease in the partial pressure of dissolved nitrogen within bodily tissues, with a corresponding decrease in nitrogen solubility, allowing nitrogen bubbles to form within the bloodstream and various tissues. Formation of nitrogen bubbles during the compression is the underlying cause of the majority of symptoms on decompression sickness. The symptoms of decompression can include musculocutaneous rash, pruritus, joint pain, cardiopulmonary chest pain, dyspnea and hemoptysis, GI abdominal pain, neurologic symptoms, alternate status obtundation, headache, visual deficit, scotoma, focal and sensory deficit. CNS can be affected by ischemic stroke or spinal cord infarction, particularly in the setting of patent foramen ovale, which allows passage of nitrogen gas emboli into the arterial circulation. Diagnosis is clinical. Treatment of decompression supportive immediate recompression with hyperbaric oxygen as well as analgesia and IV fluids. Yeah. A diver who is suspected to have decompression sickness should be administered normal baric oxygen via nasal cannula until a decompression chamber can be reached. Decompression in the water is extremely dangerous and should not be attempted. Many symptoms of DCS are reversible, but neurologic injury may be permanent. Next.
Yes, a 3-year-old girl is brought For a well child examination, her mother notes that she can ascend but not descend stairs with alternating feet. She is at 10 percentile for height and 25 percentile for weight. She copies a cross, not a square. She can count three objects correctly. She is able to stand but not hop on one foot. She speaks in five-word sentence during the examination. She shares a toy with her sibling. Which of the following is the most accurate?
Hate those kind of questions.
Ready?
Yeah, it's normal. Normal. We do step one. Sorry. I don't know. I turned off that ready thing, but somehow I don't understand if I'm the one that's not turning the notifications to things. Yeah, the notifications for it. So every time, and it's only bad notifications. It's somebody that just posted. Yeah, I swear, I'm sorry. They just
Delayed
posted.
the delayed the Reddit for some days.
Yeah, I'm like, it's just posted IMG as I fell step twice. What are my chances? So I'm like, wait, what happened? Anyway, sorry. Okay. Developmental milestones are important aspects of well child exam. They are categorized into five: motor, gross motor, social development, language findings. Expected five motor findings at 3 years includes draw a circle with the ability to copy a cross or draw a square by age 4. Gross motor skill at 3 include riding a tricycle and ascending stair with identity steps. Progressing to the ability to hop on one foot by age 4. Cooperative play demonstrated in this case by sharing a toy is normal by age 4. Lastly, normal language development finding a 3-year-old include using greater than 300 words, understanding 1,000 words, and using 2 to 3 word sentence. This patient has met or surpassed the expected development findings at her age, I guess. Next.
Okay. Studies conducted to assess whether a new drug used to treat type 2 diabetes mellitus is associated with increased risk of developing cancer. In a study of meta-analysis is performed, six small clinical trials of the new drug and relative risk of the cancer development is determined. The results of the meta-analysis are shown in the graph. Which of the following conclusion can be drawn on these data?
Ready?
Yes.
C. Why randomized RCTs, randomized control trial for the gold standard of medical research, generate more powerful evidence than other forms of
How you
observational.
find out this answer? So,
Um,
yes.
no, you tell me how you found out this answer.
No, I haven't find out. I made it wrong.
Oh,
That's
you
why
made it.
I'm
Okay,
asking.
okay, okay. Okay. This is not the good
Combined.
thing.
Yes.
Sorry. This is the combine that you're looking for. Is a relative risk, so you already know if it includes one, it's not statistically significant, right? You already
Yes.
know that. So this is the whatever, the value, and this is the confidence interval. Here, this is the value, and you see the confidence interval is just right here. It does not include one, so we know it's statistically significant. And then relative risk, I think less than one means that the exposure decreases the outcome. More than one means that the exposure increases the outcome. So here is less than one. That means that the exposure decreases the outcome. So the drug decreases the risk of cancer and is statistically significant because to see the confidence interval doesn't include one.
Okay.
Does it make sense?
Okay. I'm coming. 1 minute.
Okay.
Yes. Hello.
Did you understand the
Yes.
answer?
Concept. Yes.
Or did I already write the?
No.
No, I didn't. Okay. Randomized control trials form the gold standard of medical research and they are more powerful evidence than other forms of observational study and description. They remain susceptible to error, the RCTs. Common form of error results from limitation in the number of study participants, which in turn limits statistical power, the ability to study the study to detect the difference between groups if one exists. When the power of a study is increased, the incidence of a type 2 error decreases. A type 2 error occurs when a study demonstrates no difference between the null hypothesis and the alternative hypothesis. When in fact there is a difference, the type 2 error rate is calculated by subtracting the power from 100. Meta-analysis is a form of study in which statistical analysis is performed to combine the results of multiple studies addressing the same question. Meta-analysis is useful for overcoming limitation of the constituent studies. By pooling the results of multiple studies, meta-analysis reduces the risk of type 2 error because of the smaller sample sizes within each constituent randomized within each constituent RCT trial. However, meta-analyses are susceptible to their own error, primarily related to inclusion criteria, that's statistical methods and error of constituent studies. The meta-analysis in this um, example provides a forest plot, which is commonly used method of summarizing the results of multiple studies. The dot and diamond shape in the diagram measures of the effect observed in each individual study bounded by confidence interval represents as horizontal lines. A vertical line center on the relative risk one may or may not be shown in the center of the forest plot, representing the null effect. If the confidence interval crosses or includes the line of null effect, it implies that the observed result may not statistically be significant and may include the null value. In this example, the meta-analysis observed results that demonstrate a decreased relative risk for cancer in patients treated with the new drug. The result is statistically significant and unlikely to be true. And unlikely to be due to chance because the confidence interval of the combined result does not include one. Next.
A 27-year-old man is brought to the emergency department by his fiancée 30 minutes after the sudden onset shortness of breath, chest pain, palpitation, severe generalized discomfort. This is the patient's third visit to the ED during the past month for episodes of similar symptoms. Each time ECG showed only sinus tachycardia. He was discharged after evaluation disclosed November today. He says he has been excessively worried that he will have another episode. He has hyperlipidemia treated with atorvastatin. 2 months ago, he began bupropion for smoking cessation. He previously drank 5 12 oz beers weekly. 2 weeks ago, he stopped drinking beer altogether in an effort to decrease the frequency of these episodes. He smoked one pack of cigarettes daily for 6 years but quit. 5 weeks ago. He appears anxious, faces the room temperature 37, pulse 110 per minute, respiration 22 per minute, blood pressure 155 by 89. Physical examination discloses no other abnormality on mental status examination. He is alert, fully oriented, serum TSH. Blood alcohol zero, urine toxicology negative, ECG shows an unchanged from previous visit. Which of the following is the most appropriate next step? Which of the following is the most appropriate next step in the management while this patient is in the emergency department? So,
Ready? Omar,
yes, yes, I ready, ready.
ready?
Yes.
Sorry. Oh, no, it's okay. I just can't hear you, so I don't know if you already said ready or not. Sorry. It's Thoracic therapy. I mean, these patients with panic disorder experience panic attacks that occur unexpectedly. And associated with worry about future panic attacks, often accompanied by changes in behavior to avoid panic triggers. This patient is likely experiencing recurring panic attacks consistent with panic disorder. Panic attacks are characterized by acute fear or anxiety that peaks within minutes and associated with four additional symptoms, I guess physical and mental symptoms. These additional symptoms are sympathetic hyperarousal may include heart palpitation, tachycardia, shortness of breath, chest pain, dizziness, sensation of choking, GI distress, paresthesia, sweating, chills, trembling, derealization, fear of dying, and fear of losing control. Treatment typically includes psychotherapy, long-term SSRI, and short-term benzos. These patients later indicate that he continues to be sympathetic, hyperaroused, and could benefit from benzo treatment. It's not metanephrine concentration may indicate pheochromocytoma, rare catecholamine secreting tumor that typically presents with episodic headache, diaphoresis, sinus tachycardia, hypertension. Episodic sympathetic activation that's associated with worry about future episodes. Okay. Is consistent with panic disorders. Additionally, this patient does not report headache. Let's see this headache. Next. Never mind. No, no.
A 19-year-old woman comes to the office 2 days after a home urine pregnancy test was positive. She has 2 week history of mild pelvic cramping, frequent urination. She has not had vaginal bleeding. She thinks her last menstrual period was 7 or 8 weeks ago. Means previously occurred at a regular 28-day interval. Last 7 days ago, she has history of serious illness, takes no medication. She is sexually active with three male partner, uses condom inconsistently. Vitals and normal. Uterus is consistent with size 12 weeks of gestation. The remainder of the examination is normal. Which of the following is the most abnormal next to the mention? Ready?
Yes. Where is the thing? Transvaginal ultrasound. The most appropriate next step is diagnosis, is transvaginal ultrasound to confirm the pregnancy. Pregnancy is suspected when there is a miss or delayed menstrual period, especially in patients who report inconsistent of contraception. Beta HCG produced by the placenta is undetectable in the serum of non-pregnant women and doubles every 2 days during early normal pregnancy. Beta HCG is detected with urine and serum pregnancy tests, while ultrasound can be used to confirm an intrauterine pregnancy. Normal pregnancy and the entire gestational child should be visible by 5 weeks gestational age. On transvaginal ultrasound or when beta HCG exceeds like 1,000. Additional symptoms in early pregnancy include the mild abdominal cramping and urine frequency, as well as nausea, breast tenderness, fatigue. Data in the pregnancy based on patient history is often unreliable, as mild vaginal discharge reporting that is normal early in pregnancy can be mistaken by menstruation. Thus, ultrasound is not only used to confirm the intrauterine pregnancy but also establish gestational age of the fetus. It's not the urine pregnancy test will not be used for this patient. Surely they had a positive test at home, which was positive based on presence of beta HCG in urine. An additional test in the doctor's office will not provide further information. Transvaginal ultrasound will be the most appropriate next step as it will allow confirmation of this patient pregnancy and then in determining the gestational age of the fetus. Okay. Next. Oops.
A 68-year-old woman comes to the physician because of sadness since his wife died 1 month ago. He says he feels lost. He feels lost without her and cries whenever he talks about her. He is reluctant to socialize with his bridge group because of other members' spouses are still alive. He still enjoys spending time with his children and mm, grandchildren. He has difficulty falling asleep at night, but sleeps his usual 6 to 7 hours without awakening. He also take one short nap daily. He has decreased appetite. He misses his wife's cooking, results resulting in 2.3 kg weight loss. He has no serious illness, takes no medication. He does not drink alcohol. He is 5 feet 10 inch tall, weight 84 kg. Physical examination shows normality on mental status examination. He has a sad mood and a tearful affect. He says he longs to be with his wife again but has not a suicidal ideation. Which of the following is the most appropriate? Ready?
Mhm. So assurance and follow-up in 1 month. Acute and complicated grief presents in diverse ways and can include sadness, shock, anguish, guilt, regret, difficulty concentrating, decreased interest in usual activity, preoccupation with thoughts and memories of the disease, neurovegetative symptoms such as sleep appetite, energy disturbance. In such patients, these symptoms can endure for months. However, in uncomplicated grief reaction, the criteria for MDD are not met. This patient is not experiencing anhedonia, appears to be functioning in his activities, which makes uncomplicated grief much more likely than MDD. Management includes reassurance and normalization of his reaction, saying it's common to feel the way you do. Frequent reassessment for the development of suicidal and psych disorders such as MDD, and encouraging reconnection with family. In severe cases, the physician can facilitate referral for grief counseling. Acute and complicated grief immediately becomes integrated grief in which thoughts of the deceased continue to engender sadness with acute symptoms resolve. Psychodynamic psychotherapy is an insight-oriented psychotherapy in which patient unconscious motivations and conflicts are explored. Psychodynamic psychotherapy has been used for treatment of depression and anxiety. This patient with uncomplicated grief does not meet anxiety and depressive disorder criteria. It instead needs to recover on its own. Okay. Next.
What
Oops.
is your diagnosis?
What is it? Sickle cell? Or no.
Yes, yes.
Okay. Okay. So can you answer the question from that?
You want me to read the whole stem?
Yes, because I don't think I can answer the question from that.
Okay, a three-year a, th- a 3-year-old African American boy is brought to the office because of 3-day history of moderate pain of his chest, back, and legs. He received no medication. He appears ill. Mm, He appears sorry. Mm, He appears ill and is moderate distress on cardiac examination grade 2 by 6. Ejection systolic murmur on the left sternal border, lower extremity, no abnormal hemoglobin concentration 6.6, hematocrit 22, blood smear is shown, serum, hemoglobin electrophoresis. Which of the following findings? Which of the following findings is in this patient? Ready?
Okay, okay, I guess I should have been able to answer it without reading. Patients with sickle cell disease may develop pain secondary to vaso-occlusive event in nearly all part of the body. Patient, Pediatric patients tend to present with abdominal pain and dactylitis, while other patients may develop pain in the arms and legs. Polymerization of mutant hemoglobin is characteristic of the pathogenesis of sickle disease. Sickle cell disease is caused by mutation in the globin gene that results in abnormal hemoglobin S, which polymerizes in the setting of hypoxia or illness and causes sickling of erythrocyte. Patients with sickle cell disease have a significant decrease or complete absence of hemoglobin A. Treatment should focus on aggressive management of pain with the use of opiate or non-opiate medication and reversing any cause that may have triggered the pain cases. The mainstay of therapy includes the administration of IV fluids to treat hypovolemia, in addition to judicious use of supplemental oxygen and aggressive pain control. Most patients respond well to these conservative measures, although some may develop additional complications such as acute chest syndrome that require more aggressive treatment. Patients with frequent pain episodes should be considered for hydroxyurea.
Can you
Next.
read the option B?
Yes. Absence of hemoglobin F is not characteristic of sickle cell disease. Patients with sickle cell disease tend to have higher concentration of hemoglobin F than those in general population. This is caused by the decrease or absence in hemoglobin A. Hemoglobin F concentration are the target of hydroxyurea therapy in acute pain crisis, as hydroxyurea stimulates the production of hemoglobin F, which improves oxygenation and reduces sickling of the hemoglobin S. Next.
A previously healthy 11-month-old boy is brought to the emergency department by his mother because of cough and difficulty breathing for 2 hours. His mother says that he has been irritable and has had little to eat or drink since the onset of the symptoms. He is agitated and difficulty to exam. He has a deep barking cough. His temperature is 38.5, pulse 110 per minute, respiration 36 per minute, blood pressure 105 by 50, mild inspiratory stutter is heard. Which of the following is the most appropriate next? Ready?
One moment. Mm, mm, what was that? It was inhale. Nebula. Aerosolized albuterol. I think it's this one. I don't remember exactly. Okay, ready. Inhale cool mist humidifier. Lanning croup is an infection that occurs most commonly in children, presenting with fever, rhinorrhea, barking cough, respiratory stridor. Stridor refers to a high-pitched sound caused by turbulent airflow to obstructed or narrow upper airways, such as the pharynx, larynx, or trachea. Croup is typically mild and self-limited, but severe inflammation of the upper airway can result in life-threatening airway obstruction. Can be caused by viral or bacterial infection, most commonly by influenza. Physical examination may disclose signs of respiratory distress such as yeah. Lab studies commonly show leukocytosis and play X-ray may show subglottic narrowing of the airway steeple sign. Treatment options include supplemental oxygen, inhale, cold mist humidifier air, uh, nebulized racemic epi. That's what I was looking for. Nebulized racemic epinephrine. Nebulized. And systemic steroids. Steroids are systemic. Okay. When airway obstruction is persistent and progressive, or if the patient develops signs of progressive and persistent, signs of respiratory interference and nothing, total intubation and mechanical may be required. Care should be taken to keep children calm in such situation. Laryngospasm may be inciting event to airway obstruction. It's not B. Administration of viralized albuterol in the treatment of, is the treatment of choice for acute asthma exacerbation. This patient presents with cough, shortness of breath, wheezing. Albuterol will not be sufficient in a patient with croup as it targets small airways, not upper airways. Albuterol targets small airways. Okay, got it.
Ready?
Mm-hmm.
In the group, the initial treatment is inhale cool mist and humidified air. The next step is subcutaneous like epinephrine.
Are you asking me or you telling me? I don't understand.
I'm asking
You
you.
No, you can, usually they would, the one we are used to, they would say nebulized racemic epinephrine.
Yes,
That's the answer. But it seems like it can be either oxygen, it can be cool mist. They're not going to put all of them. It's either one of them, inhaled cool mist or systemic steroids. They're going to put one of them. But we're just used to see the nebulized racemic. So that's what I was looking for.
yes.
I was looking, yeah, and this is what this guy picked. He even picked because he saw epinephrine, so he picked that one. But it has to be nebulized. The only thing that everything has to be like through the nose, whatever, nebulized epinephrine or inhale epinephrine or supplemental. The only thing that's systemic, I guess that's oral or IV, will be the steroids. Yeah.
Okay.
Wait, it's not direct laryngoscopy is appropriate for patients with respiratory distress or failure is imminent and prompt placement of endotracheal tube is paramount. In this patient who is not currently showing signs of respiratory distress or obstruction, it's appropriate to try cold mist humidified or inhale racemic epinephrine first. Okay. Okay, so we could do. So I guess, yeah, your question would be if none of these were the nebulized, right, whatever, all this, whatever, then I guess, yeah, you will go to the next correct answer would have been direct laryngoscopy. Yeah.
Okay. A 32-year-old woman comes to the office. A 32-year-old woman comes to the office 2 days after undergoing CT scan of the abdomen because of a month history of recurrent tract infection and intermittent left flank pain. 3 days ago, she completed a course of antibiotic therapy for her most recent urinary tract infection. Today she feels well. She has no history of serious illness, take no medication, vital signs are within normal limit. Examination discloses no abnormalities, it of the abdomen, no renal calculi, but annular pancreas is noted. Which of the following is the most likely clinical course of this patient? It is ready.
Mhm. This condition will remain benign. In an annular pancreas is relatively rare congenital abnormality. It's thought to develop from incomplete rotation of the ventricular pancreatic cord during development, which leads to pancreatic tissue surrounding the descending portion of the duodenum. The majority of patients with annular pancreas are asymptomatic. The symptomatic, when symptomatic, the most common symptom include abdominal pain, non-bilious vomiting, nausea, or feeding intolerance. These symptoms can develop in the neonatal period or during childhood. Commonly seen between the ages 20 to 50, these more uncommon symptoms can include chronic pancreatitis, peptic ulcer disease, and in rare cases, biliary stones causing jaundice. Annular pancreas can be identified with CT or MRI of the abdomen. Cases of symptomatic annular pancreas and operation can relieve the potential duodenal or gastric outlet obstruction. So benign cause is the most likely expected outcome in asymptomatic patient incidentally found to have annular pancreas on imaging. Gastric outlet obstruction is a medical obstruction limiting gastric empty. Common symptoms we know those. Although annular pancreas may lead to gastric outlet obstruction, benign cause is most likely in the absence of previous symptoms. Biliary obstruction occurs when there is blockage of common bile duct, both conjugated and unconjugated concentration to increase in the serum. Causes of biliary obstruction include increasing blockage of the biliary duct. For the biliary duct, a restricted obstruction from the chronic pancreatitis of mass effect. In this scenario, the patient presents with an asymptomatic annular pancreas, which more likely remain a benign condition. Next.
Okay. A 52-year-old woman with metastatic breast cancer comes to the emergency department because of 24-hour history of severe left arm pain. She rates her pain 9 on 10 point of scale. Her only medication is hydrocodone, acetaminophen, hydrocodone 5 milligram, acetaminophen 500 milligram, 2 tablets 6 hourly, uh, 2 tablets 6 hourly 3 years ago. She has an she had upper gastrointestinal bleeding secondary to the gastric ulcer 5 years ago. She has bilateral mastectomy. She has bilateral mastectomy. 5 feet 3 inch long. Weight is 44 kg. BMI is low 17. Temperature 98. Pulse 126 per minute. Pulse high. Respiration high. Blood pressure 118 by 72. Sorry. Ready?
One moment.
Yes.
Yeah, let's see. Ready.
Ready?
So IV morphine. Pain caused by cancer is associated with significant limitations in functional status and quality of life. Opioids are potent analgesics that reduce the sensation of pain via new opioid kappa delta agonism throughout the CNS and PNS. Despite the potential for opioid use disorder and overdose death, opioid agonists are useful for management of pain in certain situations, such as perioperative period following trauma and the setting of cancer, which can produce severe chronic pain that is often intractable to other modalities. The World Health Organization has allowed the framework not as the analgesic ladder to guide escalating pain management strategy in cancer patients. Within this framework, initial management of mild pain is With non-opioid medication and adjuvant therapies, moderate pain is treated with oral opioids, typically administered on a fixed schedule dose. More severe pain is managed by increasing the dosage or frequency of oral opioids or by switching to IV opioids. Opioid dosage often needs to be increased due to progression of metastatic disease as well as development of opioid tolerance. The final step within the analgesic ladder involves invasive or um, minimally invasive procedures such as nerve blocks, ablative procedures, or intrathecal or epidural analgesia. This patient presents with acute fracture of the left humerus, typically due to metastatic disease. This patient is already taking high dose of scheduled hydrocodone acetaminophen for her body weight, and therefore, how do they know that? And therefore, they're switching to IV morphine is the most appropriate next step in pain management. Morphine is an opiate analgesic used to manage moderate to severe pain, can be administered orally or IV. It's potent analgesic that will be effective in treating pain in this patient who presents with acute fracture. Increase the dosage or dose of hydrocodone and acetaminophen is inappropriate. This patient is already a high dose of hydroacetaminophen for her body weight. Further titration of oral opioids increase the risk of respiratory depression and will have a slower onset of action. In comparison to IV morphine has rapid onset of action and is effective for severe pain. It is not to switch to IM meperidine is incorrect. Meperidine is a opioid used to manage acute pain. In postoperative shivering, it is comparable to morphine in strength, but is associated with an increased rate for drug interactions, particularly with SSRIs, and is metabolized to norpeptidine and neurotoxin that may lead to seizures. Rarely used for analgesia in palliative care for these reasons. Okay, how did they know she was already taking the maximum dose? How did they calculate that?
If you look at the acetaminophen, do you
Mhm.
know the daily how many acetaminophen can be given daily? Safe.
No, no.
It is approximately uh, 4 gram. 4 gram. So if you give, they are giving acetaminophen 6 hours, isn't it? Two tablet, like 1 gram. Two, where I am. Yes. So they are giving acetaminophen 500 milligram. Uh, two tablets every 6 hours. So two fours are 800 milligram. So 4 milligram is the maximum. So he only get the maximum 4 milligram. So if you increase this acetaminophen, then it is toxic for your liver.
So you
500
try.
500 into 8 tablet. Two tablets 6 only. So 8 tablets in 24 hours, isn't it?
Yeah, I think I'm not understanding the math. Maybe it's the math. You
I
said
am yes, this one, the acetaminophen, which is easy.
you said the maximum dose is
4 gram.
so.
So 400
for-
500 into 8. Two tablets 6 only, then in 24 hour 8 tablet, isn't it?
So
You are
the max.
sorry.
So the maximum is 8 tablets that he can
Yes,
take.
maximum is 8 tablet. That means 4 gram.
8 tablets. That means
He is already getting this maximum dose. Like acetaminophen, two tablets, 6 hourly. So in 24 hour, it is 8 tablet, isn't it?
4 times 2 and with okay, it's 8 tablets.
So 8 tablet equal to 4 gram.
Oh, okay, 8 tablets equal to 4 gram. Okay, got it.
So if you
Okay.
give more than 4 gram, then it is toxic for your liver, because in our body there is a product called NABQ or NABQ. which is which actually, what can I say, deacetylate the acetaminophen. That means it makes the acetaminophen detoxic by this NAPQ enzyme.
Mm-hmm.
So if you give more than this, more than 4 gram, that would be, your body is not uh, able to detoxic this high amount of acetaminophen, and thus causing the liver injury.
Okay.
But it is not acute. If they are getting this for a long period, then it can cause.
Mm-hmm.
But in acute case, if it is 12 gram, that means 24 tablet, it is as toxic.
Okay.
You are getting my point.
Yes, got it. Next.
And for the pedi, uh, for single dose, it is more than 7.5 gram, not 8 gram, more than 7.5 gram. You got it for a single dose. Like,
Yes. Okay.
yes, you have sent me the algorithm, isn't it? In the algorithm, the first one is the acetaminophen.
Oh, okay.
Okay.
I didn't know I had sent it to you. Okay, got it. Got it.
A 24-year-old woman, Gravida 1 para 1, comes to the physician because she has not had a menstrual period for 12 months and has been unable to conceive during this last time. Her son was born by spontaneous vaginal delivery 18 months ago, and she breastfed him for 6 months. 1 month after delivery, she has profuse vaginal bleeding and underwent emergency DNC for retained placental pregnancy. She has not used any contraception since her delivery. Currently takes no medication. She and her husband had sexual intercourse twice weekly. Analysis of the husband's semen showed no abnormality. The patient's vital signs are within normal limits. Physical examination shows no abnormality. Pelvic examination shows a normal cervix, uterus, and adnexia. Lab study shows hematocrit 42%, leukocyte 8,800, TSH 1.1, FSH 10, LH 12. Pelvic ultrasound shows no normal ovaries, no free fluid in the, no distinct endometrial stripe. Treatment with oral progesterone for 10 days produce no uterine bleeding. Which of the following is the most appropriate next step? Okay, ready?
One moment. Okay, ready. This hysteroscopy. The most appropriate next step in management hysteroscopy. Uterine synechia, a fibrous adhesion that form within the uterine cavity as a sequelae of injury to endometrium. This condition is also known as Asherman syndrome. Precipitants include endometrial trauma, in this case, curettage and infection. The typical presentation include infertility, spontaneous abortion, and menstrual irregularity, such as dysmenorrhea or amenorrhea. These changes generally result from injury involving the endometrial basal layer, which leads to formation of fibrous connective tissue bands that often breach the endometrial cavity. Diagnosis is expected based on the clinical history of the of a precipitating factor, plus consistent symptoms or complication. Lab studies will not show hormonal abnormalities. Progesterone challenge test may aid in the diagnosis, in which the patient will have no withdrawal bleeding as a result of the endometrial change. As a result of the endometrial damage, sorry. Ultrasonography may also be used, which will fail to show distinct endometrial stripe as it did in this patient. It may show the synechia. However, the diagnosis is confirmed by hysteroscopy, which allows direct visualization of the endometrium. Treatment includes removal of the adhesion to restore appropriate form and function of the endometrial cavity. Next.
Yes. A previously healthy 7-year-old boy is brought to the office because of 1 week history of diffuse mild abdominal pain and bloody diarrhea. He has a constant urge to pass stool despite passing 10 small bloody stool daily. During this time, he has had decreased oral intake. He has he last urinated 12 hours ago. He has not had fever or vomiting. No other family members are ill. No other family members are ill. The patient appears tired and his temperature is 37.7 degrees Celsius. Pulse is 120 per minute. Respiration 26 per minute. Blood pressure 120 by 85. Examination shows pallor or tacky mucous membrane. The lungs are clear to auscultation. A grade 2 by 6 systolic murmur is heard. The abdomen is soft and diffused with tender palpation. There is no rigidity or rebound. Examination shows perianal area and diffuse abnormality. Last studies are showing hemoglobin 7. Hematocrit 21, leukocyte 12,000, platelet 14,000, sodium 147, potassium 4.2, chloride 118. Bicarbonate 14. So bicarbonate is low. But urea nitrogen is higher, isn't it?
Yeah.
And creatinine is high, which of the following is the most likely infectious agent? Ready?
One moment. Ready. It's E. coli. HOS most likely explain this patient's acute kidney injury, thrombocytopenia, and microangiopathic hemolytic anemia. HOS is typically seen in children and is often caused by infection with Shiga toxin producing E. coli 0157H7, which is usually accompanied by bloody diarrhea. There are typical variants of HOS which are not preceded by diarrheal illness and are the result of mutations in the complement system. Um, Widespread microvascular thrombosis consumes platelets and predisposes circulating erythrocytes to shear impulses as a result of disrupted vascular lumen. When erythrocytes come into contact with microvascular clots, they are damaged, resulting in schistocytes, which are apparent on peripheral blood smear as fragmented cells. Thrombosis also occurs in the kidney vasculature due to underlying endothelial damage, resulting in kidney injury. Differentiating HOS from DIC is important and can be done by examining the PT levels, normal in HOS and increase in DIC as a result of clothing factor construction. Clothing factor consumption. Treatment of HOS is supportive, although eculizumab and monoclonal IgG antibody against complement protein C5 that prevents formation of the MAC has been used in refractory cases. Antibiotics are avoided as they can result in increased release of sugar toxin and worsening clinical deterioration. Yes. Next.
Yes. A previously healthy 5-year-old boy is brought to the physician because of progressive muscle weakness over the past 6 months. Examination shows fish-like mouth with a high-pitched arch palate, wasting of the distal muscle and hypotonia. Deep tendon reflex are intense and symmetric. Which of the following is the most appropriate? Which of the following is the most likely diagnosis?
Fish. Feel like the fish-like mouth is a key, but I forgot what it was. Myasthenia gravis, progressive muscle weakness, 6 months, high arch plate, wasting of distal muscles, and hypotonia. The tendoriferous are fine, so it's not this. I forgot what was Pompe disease, child. Maybe it's Pompe disease. I don't know, I guess.
Why you are
I forgot.
thinking
I
that?
don't know what. I knew it was I know the fish like mouth is a key, but I just forgot what it.
Stop thinking the fish-like mouth. Progressive muscle weakness. Now you think.
You can see progressive muscle weakness ascending on Guillain-Barré. You can also see. I guess you cannot see in hypothyroidism. Fine. It's not myotonic dystrophy because the deep tendon reflex are fine. So I'm between myasthenia gravis and I guess myasthenia gravis.
Why not myotonic dystrophy?
Because that's the myasthenia dystrophy. Wait, isn't it the one where you say you give your hand to somebody and it's hard to
Handshake,
lift?
difficult grip myotonia,
Yeah.
orofacial myotonia. You were talking about this. Have you have you seen the face of those people? The
No.
adult myotonic dystrophy. Just see the face of adult myotonic dystrophy patient.
Myasthenia dystrophy adult patient face. Let me see. Maybe I will never forget. Oh,
Now, what is your impression now?
I guess this one, like the fish one.
Yes. Like
Um,
the second one in the wiki. What
this
is
one.
yes? What
Yeah,
what do you say? Isn't
yeah, like fish. I never seen the face. Yeah, like fish kind of thing.
yes?
I
That's
know.
all.
Yeah,
Now
I know
you
you have
yes.
seen it.
Pompey pumps the heart. Pompey is not. Pompey is related to heart. They are in so Pompey disease to happen. You have to have the heart feature. Without
Hard.
heart feature, there the Pompey cannot be established.
Got
Like I remember in that way. Like
it.
look at the feature of the Pompe disease, cardiomegaly, cardiomyopathy, all the heart. There is other also like hepatomegaly myopathy, but without heart feature, Pompe cannot happen.
Got it. Myotonic dystrophy genetic disorder caused by expansion of the nuclear repeat, which occurs when a series of three nucleotides in repetition are replicated incorrectly and too many repeats are included in the replicated product. Myotonic dystrophy has several phenotypes, but all are characterized by muscle weakness and myotonia, defined as delayed relaxation following a normal contraction of the muscle. The most frequently affected muscles include the facial muscle, where the muscle weakness can present with a fish-like mouth and high arch palate. Sternocleidomastoid distal forearm muscles, intrinsic hand muscles, and ankle dorsiflexus. Classic myotonic dystrophy presents during the second, third, and fourth decades of life. With muscle weakness, myotonia, cataracts, frontal balding, cardiac arrhythmia, and hypogonadism. However, symptom onset in the first few years of life is also common. Life expectancy slightly reduced for patients with classic myotonic dystrophy, and premature death is most commonly caused by respiratory or cardiac dysfunction. Glycogen-storing disease type 2 Pompe disease is an inherited recessive disease that causes cardiomegaly, cardiomyopathy, hepatomegaly, myopathy, and hypotonia. The infantile form commonly includes weakness of the diaphragm and other breathing muscles, while the juvenile and adult form commonly presents with proximal extremity or diaphragm weakness. This patient presents with facial and distal muscle weakness, which are more typical of myotonic dystrophic. And it's not, I guess it was the myasthenia gravis, autoimmune neuromuscular disorder characterized by muscular weakness, fatigue, diplopia, and ptosis that worsens toward the end of the day, along with dysphagia and potential respiratory distress. Typically affects adults and only rarely presents in childhood. This patient hypotonia, wasting of the distal extremity muscles are typical, atypical of myasthenia gravis. Okay. You'll never forget the fish mouth. Next.
Okay, next. A 77 a 77-year-old man comes to the physician for an initial visit. He has a history of gout and surgical repair of hernia. He has been told that he has a mild cardiac murmur and he thinks that he had rheumatic fever as a child. He takes no medication. His pulse is 80, respiration 14 per minute, blood pressure 150 by 92, a grade 4 by 6. Systolic murmur is heard best at the second right intercostal space. It decreases in intensity with Valsalva maneuver with hand grip, and increases in intensity when squats. There is a source systolic thrill, palpable at the base, which of the following is the most likely cause.
Valsalva means less blood to the heart, right? Yeah, less blood to the heart. And it says it decreases with less blood to the heart.
Stop looking at the Valsalva. Look at the right second intercostal space.
I know the right second can be aortic, is the aortic, we know, but it
Yes,
can be aortic
aortic, aortic stenosis and
or aortic insufficiency. But I guess aortic insufficiency will be diastolic, and this is a systolic. Yeah, I guess it's aortic stenosis. Okay.
yes, you are right.
Let's see. Aortic stenosis, common disorder of the aortic valve that results from fibrosis and calcification. These changes of aortic valve are pathologic consequence of mechanical stress of the heart valve, a result for repetitive microtrauma from the opening and closing of valve leaflets with associated chronic inflammation. Many people will develop some degree of aortic stenosis over time, but structural abnormalities of the valve, such as the bicuspid aortic valve, alter the biomechanics of valve opening and closing and increase the likelihood of early fibrosis and calcification. With consequent stenosis, while many patients may be asymptomatic, those with severe aortic stenosis may experience fatigue, shortness of breath, cough, diminished exercise tolerance, angina, syncope with exertion. Cardiac exam will disclose a decrescendo systolic movement. Aortic stenosis, best heard at the upper right sternum, burden with radiation to the carotids and pulses, pivot, status, weak and delay pulses, peripheral pulses. The murmur of aortic stenosis decreases in intensity with increasing afterload. Decreases in intensity. Okay, yeah, makes sense. And decreasing preload. Okay. And increases in intensity with increasing preload. How does squatting increases the pace? Squatting increases the preload. How? Never mind. Hmm, Wait, give me a second. I want to know.
yes, yes. These things are complicated.
How does squatting increases preload? Squatting increases by enhancing venous return to the heart, compression of the leg veins, which forces blood back to the heart. Okay, okay, got it. I guess. and Valsalva stops blood from going to the heart because it forces the veins to close. Okay, makes sense, I guess. Okay, next.
Okay. A 54-year-old woman, a 54, a, fif- a 54-year-old woman comes to the office because of 2-day history of increasingly severe pain in her, increasingly severe pain in her, okay. Increasingly severe pain in her right ear. She states the pain is 9 on a 10-point scale. She has mild ringing sensation in her right ear. She adds that this morning her usual cereal tasted awful to her and she vomited once. She has no symptoms in her left ear and has no had fever, headache, neck stiffness, or symptoms of an upper respiratory tract infection. Her most recent vaccination was 3 years ago for influenza. She has no history of serious illness, takes no medication, has no known allergies. She is 150 centimeter. She is 165 centimeter, 5 feet 5 inch tall, weight 72 kg. BMI 26 kg per meter square. Temperature is 37.3 degrees Celsius. Pulse 84 per minute. Respiration 16 per minute. Blood pressure 125 by 85. Examination of the left pinna and the tympanic membrane discloses no abnormality. Examination of the right ear shows erythema edema of the exterior auditory canal and pinna. Light touch of the right pinna produces pain. The right tympanic membrane cannot be observed because of pain and edema. Cranial nerve testing discloses a widened right palpebral fissure. The patient has decreased ability to close her right eye and wrinkle her forehead and smile. Visual acuity of the visual acuity and the visual field disclose no abnormality. Sensation of the light touch pinprick or is intact, no abnormality. Which of the following condition most likely developed? Okay,
Ready?
yes.
Oh, it's ocular auricular vesicles. Auricular vesicles associated with ear pain, tinnitus, altered taste perception, and facial nerve palsy are suggestive of Ramsay-Hunt syndrome. Oh. Ramsay-Hunt syndrome, also called zoster oticus, results from the activation of the varicella zoster virus within the genicular ganglia. The genicular ganglia associated with facial nerve, but damage may spread to the vestibulocochlear nerve. Patients with Ramsay Hunt syndrome develop a constellation of symptoms including um, facial nerve palsy, ear pain, hearing abnormalities, vertigo, ipsilateral altered taste perception, and development of vesicles within or on the auricle. The diagnosis may be made clinically, however, diagnosis can be confirmed with PCR testing using a swab obtained from vesicular fluid. In patients with suspected Ramsay-Hunt syndrome, antiviral drugs, including acyclovir and acyclovir, are recommended in addition to steroids. It's not xerostomia as multiple causes, including adverse effect of oral medications, and may be associated with other conditions such as Sjogren syndrome, which is autoimmune disease associated with development of anti-Ro and anti-La antibodies. Patients with Sjogren syndrome develop Characteristic ocular dryness, showing a treatment testing salivary hypotension and xerostomia. This patient constellation of history consistent with Ramsey hand, which is associated with development, which is not associated with development of xerostomia. What was the mnemonic for the Bell's palsy, like upper spells the
Yes, for upper motor neuron type of Bell's palsy, upper part of the face spared. What does it mean? Upper and in the lower motor neuron type of facial palsy, like Bell's palsy, all the part of the face is involved. So when you look at the face of a patient with a seventh nerve palsy, what you will see? You will ask the patient to look upward to see for wrinkles. You look upward, there is a wrinkle, isn't it? Wrinkle in the
Mhm,
forehead. And for Bell's palsy, there is absence of wrinkle on the forehead, and eye cannot be fully closed on the affected side. There is patient is unable to whistle. There is loss of nasolabial fold. Patient cannot blow, patient cannot whistle, patient cannot puff his cheek, and mouth is deviated to the opposite side. If somebody has like left right-sided lower motor neuron type of facial palsy or Bell's palsy, then mouth will be deviated on the left. You got my point. And
mhm,
for it is for the lower motor neuron type of palsy or Bell's palsy. And for upper motor neuron type, the upper part spares. That means patient can wrinkle. So when he looks upward, he there is wrinkling, and he can close his eye, and the rest of the lower part of the face, that means he cannot whistle, he cannot puff his cheek, and mouth, there is accumulation of food within the mouth while swallowing, and face is deviated to the opposite side. And along with in the upper motor neuron type of facial palsy, there is presence of long tract sign. The long tract sign means there is in this patient, if you do the Babinski, it will be positive. If you do the Hoffman test, it will be positive. You got my point. If you do
mhm,
the pyramidal test, like upper motor neuron test, it will be positive.
mhm.
And
Okay,
that's the difference.
got it.
Am I explaining too much?
No, 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 no,
Okay.
no.
And for this patient, we will also see the heart palate and the air for this Ramsay Hunt syndrome.
Yeah, okay.
And finally, you need to do the mm, eighth nerve test, like the Rini and the Weber test, for any sort of hearing problem present or not. Okay,
Mhm,
I'm okay. Next, in the NBME and the CMS form, the X-rays are very bad. This type of X-ray, it is very hard to interpret.
yeah.
ECG is noticeable, but X-ray is very tough. Okay, a 42-year-old woman is brought to the emergency department by paramedics 30 minutes he, after she was struck by a car while she was riding on her bicycle. She has no history of serious illness, takes no medication. She is alert and fully oriented. She has moderate left upper abdominal and flank pain. Temperature is 37.1. Pulse is 118 per minute. Respiration is 25 per minute. Blood pressure 88 by 60. Pulse oximeter on room air show oxygen saturation 94%. There is 5 into 7 inch tender ecchymosis over the left upper abdomen, ardent and left flank balsams are normal. The remainder of the physical examination shows no abnormality. Neurologic examination shows no focal findings after administration of 2 liters of Ringer's lactate solution. Pulse is 105 per minute, blood pressure 95 by 70. The transfusion of the 2-unit pack red cells is begun 30 minutes later. Pulse is 80 per minute, blood pressure 124 by 80. Blood pressure 124 by 80, pulse oximetry, FiO2, NRB 1.0 via NRB. Non-rebreather face mark shows an oxygen saturation 100%. CT scan of the abdomen show grade 3 splenic laceration. The patient is admitted to the surgical ICU for non-operative management. 3 hours later, she has progressive difficulty breathing, temperature 37.2, pulse 90 per minute, respiration 30 per minute, blood pressure 110 by 70, pulse oximetry shows oxygen saturation 87%. On pulmonary examination, breath sounds and diffuse crackles are heard. Bilaterally heard sounds are normal. Abdominal examination is unchanged. Chest X-ray is shown which of the following is the most likely cause of this patient's current condition.
Ready?
Yes,
Traumatic related acute lung injury. Rally is a rare complication of blood transfusion, but the common cause of death related to transfusion. It commonly presents during or within like 6 hours after administration with symptoms of fever, diagnosis, hypotension, hypoxemia. Physical exam may disclose crackles on auscultation of the lungs. A chest area will show new bilateral pulmonary infiltrates. Unrelated to cardiac dysfunction, the pathophys is thought to be caused by activation of neutrophils in the pulmonary vasculature by antibodies in the blood, transfused product, which leads to release of cytokines and inflammatory mediators. Risk factors for its development include patient risk factors include patient risk factors such as tobacco use, fluid overload, shock, alcohol use disorder, platelet, plasma, and whole blood carry the greatest risk for TRALI. Treatment includes discontinuation of transfusion, oxygen, giving oxygen in the form of MP, non-invasive positive pressure ventilation or intubation, and hemodynamic support. It is not C. Bilateral pulmonary contusion may occur after blunt or penetrating trauma to the chest. They often underlie the region of trauma to the chest wall and result from damage to capillaries with associated leakage of intravascular and extravascular fluid into the pulmonary interstitium and alveolar space, respectively. On chest X-ray, pulmonary contusion appear as interstitial infiltrates. On chest X-ray, okay. Interstitial infiltrates and partial alveolar opacities. This patient trauma was focused to the left upper quadrant of the abdomen, making bilateral pulmonary contusion. Okay, makes sense. Traumatic intrapulmonary hemorrhage can be seen in patients with significant trauma to the chest. These patients will generally quickly develop shortness of breath and evidence of hemoptysis. Given this patient transfusion history and no hemoptysis, this is unlikely. Okay, next.
if a 12-year-old girl is brought to the emergency department by paramedics 10 minutes after she was stabbed in her chest with a stick knife by another girl after school. The patient's medical history is unknown. She is gasping for breath but able to say her name. Temperature 37, pulse 140 per minute, respiration 36 per minute, blood pressure 80 millimeter of mercury. Breast pulse oximetry FiO2 1 NRV mask shows an on oxygen saturation 86%. An examination discloses 2 centimeter stabbed wound to the left of the sternum. Jugular venous pressure 12 centimeter. Breath sounds are equal bilaterally. Heart sounds are decreased. The abdomen is soft, non-distended. Pulses are decreased in all extremity. Cardiopulmonary, pericardiocentesis yields 30 ml of non-clotting blood in addition to IV fluid resuscitation and typing in crossmatch. Which of the following? Next step. Ready?
Yes. Oh, sternotomy. This patient with hypotension, muffled heart sounds, jugular venous distension after a penetrating trauma likely has cardiac tamponade secondary to ventricular injury. Cardiac tamponade is characterized by rapid accumulation of blood or fluid in the pericardial space that prevents the systolic filling of the cardiac chambers, leading to low cardiac output due to low stroke volume. The speed of accumulation is important in the pathophysiology of tamponade. In the gradual accumulation, permits stretching and expansion of parietal peritoneum without necessarily impairing chamber expansion. In cases of hemodynamic instability, when the pretest probability of the condition is high, the pericardial space should be decompressed without delay. This is accomplished by pericardiocentesis, in which a large needle of orangiocatheter is inserted into pericardial space via subxiphoid or parasternal approach to evacuate the fluid or blood and permit chamber expansion. Echo permits visualization of the heart and its chambers, and in cases of tamponade will show pericardial effusion. Um, okay, where is my pericardial effusion of variable size with right ventricular collapse during that study. In general, the patient in this case may receive bedside emergency echo while preparing for pericardiocentesis. But managing imaging should not delay intervention in an unstable patient, as in this case. After initial stabilization with pericardiocentesis, the patient should be emergently taken to the OR for open sternotomy and thoracotomy and definitive repair of any cardiac defects. Snap checks X-rays often done early in the setting of trauma after the primary surgery is complete, and there are no immediate life threats identified. Checks X-ray can identify many pathologies, including pneumothorax, rib fractures, hemothorax, um, alveolar hemorrhage, and one mediastinum. This patient has sustained life-threatening injury that has been temporized with pericardiocentesis, and she should be taken immediately to the OR room for definitive management. Now, CT angiogram of the chest can be used to identify the intrathoracic vascular injury in the setting of trauma. This patient is hemodynamically unstable, should not be sent for any imaging as this will delay definitive management of a condition. And transesophageal echo permits visualization of the heart and its chamber and in cases of tamponade will show pericardial effusion of variable size. Although echo can be useful, the diagnosis in this case has already been made by the patient's clinical response to pericardiocentesis, and definitive management should not be delayed by obtaining imaging. Okay, next.
Next. A 68-year-old woman comes to the office for a routine examination. She says she has felt well. Medical history is remarkable for hypertension, type 2 diabetes, melatonin medications for heart and blood at her atorvastatin and insulin. Pulse is 70 per minute. Respiration 14 per minute. Blood pressure 130 by 60 millimeter mercury. Physical examination discloses 2 centimeter mass in the right groin, 2 centimeter mass in the right groin below the inguinal ligament. The mass is mildly tender to palpation and does not reduce. With the attempts at manual reduction, the mass is not fluctuant. The patient says she has noticed this abnormality during the past several weeks, but has been bothered by it the remainder of the physical examination disclosed no abnormal fasting glucose concentration obtained in preparation for today's visit within the reference range. Which of the following is the most appropriate recommendation at this time? Ready?
Yeah, yeah. It is selective for operative repair within the next week. Femoral hernias occur much less frequently than inguinal hernia. In general, hernias occur secondary to weakness in the muscle and connective tissue of the anterior abdominal wall. Hernia contents may include preperitoneal fat or may contain intra-abdominal contents such as bowel. Yeah. Femoral hernias occur in the femoral canal and are often identified as a bulge below the inguinal canal. Many hernias are easily reducible and asymptomatic. However, if the hernia contents become incarcerated within the hernia sac or if strangulation occurs, impending blood supply, and operative emergency arises. Femoral hernias have the highest rate of strangulation and cancellation. A strangulated hernia presents with severe pain in the hernia site, often with underlying reactive erythema, fever, and a tender irreducible mass on examination. It is recommended that femoral hernias be repaired operatively rather than after watchful waiting. In this case, elective operative repair within the next week is more appropriate recommendation because of the high frequency of femoral hernias becoming incarcerated. Now, CT scan of the pelvis may be used to further characterize and evaluate the small bowel or tissues involved in the hernia. However, most inguinal and femoral hernias do not require further imaging studies to formulate uh, a diagnosis. The most appropriate recommendation is selective. Blah, blah, blah. And it's not the evaluation of in the office if symptoms develop may be reasonable. Recommendation in case of inguinal hernia. Um, Femoral hernias, however, have a rate of incarceration that's high. The most appropriate recommendation is elective repair. Next.
Femoral hernia is always below the inguinal ligament, isn't it?
Yeah.
And the inguinal is above the inguinal ligament.
Above or goes through the inguinal ligament, the direct or indirect.
Okay. An 18-year-old woman comes to the physician to a request of a prescription of an oral contraceptive. She has been sexually active since the age of 17 years and has never used a contraception. Menarche was at age 12. Mens occur at regular 28-day interval. Her last menstrual period 2 weeks ago. He received all appropriate child vaccination since age 6 years. She has smoked one pack of cigarettes daily for a year. Physical examination include pelvic showing abnormality in addition to recommending condom use by partner. Which of the following is the next step?
I forgot the age for pap smear. Was it 21 to 65?
Which
Forgot.
one?
For pap smear, was it 21 to 65? I forgot. Is it a pap smear or rubella? I don't know why rubella will be this. I don't know. Oh, it says she has childhood immunization but none since the age of, maybe it's rubella. But I forgot what was the age of pap smear. Was
Why
it,
you are thinking so complicated?
okay, what were you thinking then?
She came here for contraception. I will give contraception.
But how you gonna give oral contraception if she smokes?
So what happens? If somebody smokes, he cannot take contraception. It is
Oh, I
it is
thought
not.
oral.
No, it is not absolute contraindication.
Oh, I thought oral contraception has estrogen, and with the smoking, you cannot give estrogen because
Mm,
of the risk.
no, it doesn't uh, go like that.
Oh,
It
oh,
it it creates an impact to the patient, but her primary concern is contraception, isn't it?
okay.
So I will give contraception, even if she dies with the contraception.
Oh, oh, okay, okay. Let's check.
Isn't it the way of thinking?
Okay, okay. I did not see that one coming. Okay, okay. Whoa.
I remember your first impression while you have started this nmbe.
Yeah. I'm like, what? That did not. I did not see that one coming. Okay. Many methods of contraception exist, including temporary and
We
permanent
have to
options.
be cruel.
That's crazy. Just including temporary and permanent, hormonal and non-hormonal or oral medication, injection, implants, whatever. The most appropriate contraceptive method is dependent on the patient and the goals of care. Counseling regarding contraceptive options should determine if the patient wants long-term or temporary contraception, whether they are able to be compliant with the medication every day, their menstrual history, and comorbidities that may make some options contraindicated. Oral contraceptives are temporary form of birth control that must be taken every day. They most commonly include a combination of estrogen and progestin, although progestin only options are available. Okay. Oral contraceptive work to prevent pregnancy by thickening the mucus, cervical mucus, thinning the endometrial lining, and decreasing ovulation. While very effective in preventing pregnancy when taken as instructed, there are important contraindications to prevent cardiovascular morbidity and thromboembolism. For example, oral contraceptives are contraindicated for patients who are 35 or older and smoke. So you have to be 35 years old, 35 years or older and smoke. Although they are not contraindicated for younger patients who smoke. Okay, that's the key.
Hmm.
That's the key. It's because she's young. If she was old, we wouldn't give the oral contraceptive. There are
35
also
or 35 or more.
mm, they
So
are also contraindicated for, yeah, because it was like it doesn't make sense. I think she smokes, but okay, I heard you have to be 35. They are also contraindicated for patients with increased risk of cardiovascular events, hypertension, blah blah. History of stroke or thromboembolism, cirrhosis, migraine with aura, breast malignancy with estrogen, or progesterone receptor positivity, none of which is present in this case, therefore the most appropriate. Blah, blah. Obtain rubella antibody is not necessary in this visit, but should be determined prior to the patient becoming pregnant. Rubella infection of a pregnant patient can cause sensorineural deafness. We know this patient is requesting oral contraception to avoid pregnancy and has had all of her childhood immunization, thus obtaining blah blah blah. Perform pap smear as screening modality is not recommended for 18-year-old patients, even if they are sexually active. Additionally, a pelvic or speculum exam and a pap smear are not required prior to prescribing oral contraceptive. However, they should be started after a patient turns 21. Okay, so it's 21 to 65. Yeah, pap smear. Okay, so that was a good question because I would have never. I just usually see smoke, contraceptive, and I'm like, no, we
no,
cannot give. So,
yes,
okay, but I guess you have to be 35 and now. Okay,
they
I got it.
changed it.
They changed. Oh,
Okay. A 77-year-old woman with chronic obstructive pulmonary disease comes to the physician for a follow-up examination. He has bronchitis 3 years ago, treated with amoxicillin and prednisolone. He has not hospitalized during the past 3 years. He has a history of shortness of breath, cough. He has history of shortness of breath and cough, but says symptoms have subsided since he quitted smoking cigarettes 5 years ago. His only medication is inhaled ipratropium. Pulmonary function testing showed FVC 85% predicted. FVC 85% predicted FEV1 75% predicted. The patient says he heard about a new inhaled medication called Breathe Easy for management of the COPD and asked if he would benefit from this medication. The physician recalls recent randomized controlled trial evaluating the efficacy of Breathe Easy in 7,500 patients with COPD. Uh, patients were randomized to receive Breathe Easy or placebo. Breathe Easy or placebo and observed 4 years data. Analysis shows mortality rate 12.2% for the patient receiving Breathe Easy and 15.4% receiving placebo. Mm, Hazard ratio 0.79, 95% confidence interval 0.63 to 0.98. Based on this data, which of the following is the most appropriate action regarding Breathe Easy?
Ready?
Ready? Yes.
Okay. D. Do not prescribe it easy because the results apply only to patients with more severe COPD. To correctly apply the findings of the study, the person to whom the
What
study is
makes you
applicable.
choose this answer?
Uh, what made you choose this
Sorry.
answer?
Yes.
You, but you tell me what made you choose the answer.
It uh, it applies only in the more COPD. It has mortality rate of the breath is good. Uh, but I haven't find where I
Wait, sorry, did you choose the, that's my first question. Did you
no.
choose the answer? Okay, okay, sorry. I thought you meant, I chose this one because I just eliminated all the other ones. It didn't make sense. Like, do not prescribe it easy because the medication is not efficacious. It
It,
doesn't talk about efficacy nowhere here.
yes.
Nowhere here. This is the mortality rate. This is not, nothing is efficacious. That doesn't make sense. Do not prescribe it easy because the results are invalid as a result of difference between the placebo and treatment group. They didn't say anything. I don't. They just said they selected 7,000 patients. They didn't say anything about each group like if they were matched by age or whatever. And actually, here, if you look at the age, they both sides are 65. So both sides are kind of around the same age. Both sides have smoker and former smokers around the same amount. So they didn't really go into the specific of each group, so it doesn't make sense. Do not prescribe Breathe Easy because the results are relevant only for younger patients. That's definitely not true. We have 65 years old, 65, so this is definitely not young people. And then prescribe Breathe Easy. This is never the right answer. Never. So yeah, just no.
But
So
straightforward, this D option, what I will look at
it
in
says
this.
because do not prescribe because the result only apply to patients with more severe COPD. If you see on the question, it says that the patient has not had an exacerbation of COPD in like 3 years. So it's been 3 years without. So he's actually controlling, and his FPV and FVC, they are really good. He's actually controlling his COPD.
Okay,
But here, the patients on here, they says number of COPD exacerbation during the prior 12 months. So during the prior year, they have 3 exacerbations. So these are patients that actually have severe COPD. They have exacerbations like 3 times a year. This guy has not had it in 3 years. Has not had it. So his thing is like really minimal compared to these people on the these people on the thing on the
okay.
thing. So this thing doesn't even apply to him actually because he doesn't have severe COPD like these people on the thing. Does it make sense?
Yes, elimination is far better than the
Yeah, I think it's
option
fair.
B.
Yeah. I think elimination is better. To correctly apply the findings of a study, the person to whom the study is applicable must be considered. Generalizability refers to ability to apply the result of a study conducted with a sample population to the population at large and reflects the external validity of the study. Typically, the results of a study are generalizable to a similar patient or population as those included in the study and with a similar clinical condition. In this scenario, a randomized placebo-controlled trial has evaluated the efficacy of breath ease in patients with severe COPD based on their spirometric values, moderate to severe exacerbation, blah, blah, blah. The patient described in this case has much more milder, so a mild COPD, because as shown by the pulmonary function test, it has minimal symptoms that are well controlled. This patient is therefore dissimilar, it's not similar to the people in the study. The reduced mortality rate in the study is statistically significant, but these results can only be generalized to patients with a similar disease status and severity and do not apply to the patient in this case. Next.
A 44-year-old woman comes to the physician because of 4 month history of dryness of her mouth. During this time, she has consumed liquids to aid in swallowing. She has not had she has not had sore throat or fever. She has not sustained head or neck trauma. She has rheumatoid arthritis. Her medication is low-dose aspirin, low-dose prednisolone, and ibuprofen vials, and skin target is normal. Examination through erythematous dry oral mucus and atrophy of the filiform papillae on the dorsum of the tongue. Results from Roe and La is positive. The patient is given water to drink. Which of the following is the most appropriate pharmacotherapy? Okay,
Okay. Is
Children's.
pilocarpine. This patient presentation is consistent with shrug and autoimmune disease characterized by chronic lymphocyte infiltration and destruction of a lacrimal and salivary gland. The presentation typically includes dry eyes, dry mouth, painless bilateral parotid enlargement. Primary Sjogren occurs in the absence of concurrent rheumatologic disease, while secondary Sjogren's occur in the setting of another rheumatologic disease such as rheumatoid arthritis, lupus, scleroderma. Diagnosis is clinical and may be supported by a variety of lab studies, although no single study is diagnostic. Antibodies against Ro and La. are present in most patients. Many patients also positive for rheumatoid factors. Streamer testing is performed by placing a paper measuring strip in the lower fornix of the eyelid, measuring tear production over 5 minutes. Production of less than 5 millimeters of tear is considered abnormal and consistent with shortness. Salivary gland biopsy is not necessary for diagnosis, but classically shows CD4 lymphocyte aggregates and replacement of normal glandular architecture with lymphocytes. Treatment is with topical eye lubrication as well as oral pilocarpine. Pilocarpine is a muscarinic agonist that increases secretion of tears and saliva. Adverse effect of pilocarpine may include sweating, headache, dizziness, nausea, diarrhea. Not TCA, sorry, amitriptyline is a TCA that is useful for the treatment of fibromyalgia. Fibromyalgia presents with fatigue, headache, musculoskeletal pain, and sleep and cognitive disturbance. This patient presents with xerostomia and lack of musculoskeletal symptoms. Rendering fibromyalgia unlikely. Okay.
Ready? Next.
Mm-hmm.
A 27-year-old woman gravided with para 1 12 weeks of gestation gone to the physician for her first prenatal visit. 18 months ago, her first pregnancy ended in term low transverse cesarean section 30 weeks of gestation because of fetal bradycardia and following the onset of the contractions. A pap smear 16 months ago showed low-grade squamous intraepithelial lesion. She has not had a pap smear since then. 3 years ago, she underwent loop electrosurgical excision of the CIN cervical transformation zone for cervical intraepithelial neoplasia CIN3A. She has 10-year history of cocaine use, has not had has not used cocaine during the past 12 months. She used cocaine intermittently. Her first pregnancy smoked 1 pack of cigarettes. Okay. Examination show uterus consistent in the size of 12 weeks of gestation. The fetal heart rate is reassuring greatest risk. Okay.
Okay. Ready?
Yes.
Okay. So it's pretend delivery. This patient with a history of preterm labor and CIN is the greater risk for preterm delivery with pregnancy. With this pregnancy, preterm labor occurs after 20 weeks and prior to 37 weeks gestation with regular uterine contractions and accompanied by cervical change. The diagnosis is often based on history and physical exam, although ancillary tests such as a measurement of cervicovaginal fetal fibronetic oscillation may be done to aid in evaluation. Risk factors for its occurrence include personal history of preterm delivery, previous CIN, previous cervical surgery or dilation and cartilage. Um, okay. Short cervix, extreme of age, hypertension, diabetes, tobacco, multiple gestations, malnutrition of the mom. In patients with high risk of preterm labor, prophylaxis is accompanied with intravaginal progesterone supplementation in addition to treating any underlying risk factors. If premature labor does occur, the degree of fetal mobility increases in the early the preterm labor is. For this reason, is usually treated with tocolytic therapy, hydration, and bed rest. Steroids are also given to promote fetal maturity. If gestational age is less than 34 weeks, and magnesium is given for neuroprotection if gestational age is less than 32. Abrupto pacientes premature separation of placenta from the endometrium. Presenting findings include abdominal and pelvic pain, abnormal vaginal bleeding, tetanic contractions. Typically, in the third trimester, an abnormal fetal heart rate may be detected, and fetal demise may occur if the abruption is large. Okay. It commonly results from lower abdominal trauma, smoking, cocaine use. This patient currently has no risk factors for the development of placenta. Oh, I thought she stopped smoking. Never mind. I guess no. Of 6 months ago. Okay. Fetal growth restriction occurs when the fetus fails to reach its genetically determined growth potential and is defined by estimate fetal weight less than 10 percentile. It may be identified by smaller than expected fundal height and range of
Fetal growth restriction, estimated fetal weight is less than 10% and birth weight is less than third percentile, isn't it? And
um
and it is divided into symmetric and asymmetric. Symmetric happens in the first trimester and asymmetric second and third trimester. For symmetric, the congenital infection and the chromosomal abnormalities, and for asymmetrical, it is uteroplacental insufficiency and maternal malnutrition. And symmetric is like globally there is growth lag, and for asymmetric, I think so there is head sparing growth. Okay.
Perfect. It's associated with preeclampsia, diabetes mellitus, tobacco, fetal chromosomal abnormality, maternal or neonatal infection. Next.
A 13-year-old girl is brought to the physician by her parents because of changes in the behavior during the past 6 months. Her parents say that during this time she has been hostile and unpleasant, frequently crying and screaming about treated unfairly no matter what they do. She also has alienated her friend. Her grades have declined from mostly B's. Her grades have declined mostly B to C's and D's. She had stopped participating in sports. The patient says that she is tired, does not sleep. Her parents report that she is sleeping more than usual. They add that she has been eating more, resulting in 10 kg weight gain, which bothers her. 10 kg weight gain, uh, which bothers her. They say she was a warrior and when she was younger, but her worrying has decreased during the years. The patient is at 45 percentile for height, 60 percentile for weight. Vital signs are within normal limit. Physical exam, no mental strategic emotional. She describes her mood as okay but appears dysphoric and has irritable effect. She looks at her hands and responds slowly using monosyllabic words. She says, I don't think I'm depressed, I'm bored and angry because no one likes me. I used to want to be an actress, but nothing even works out for me. I could do it if my parents would let me do. Her thought process is goal directed. She says that adults, especially her parents, do not understand her and make unreasonable demands. There is no evidence of psychosis. Which of the following is the most likely diagnosis?
Jesus. Yes. Hmm. I don't know. It's complicated, this one. Ready?
Yes.
Okay, I guess it's MDD. That was hard one. This patient meets criteria for MDD diagnostic include 2 or more weeks of at least 5 of the following: depressed mode and hedonia, guilt or worse, listening difficulty, constant psychomotor delay, suicidal thought, and like decreased energy, sleep disturbance, decreased appetite, or weight changes. In children and adolescents, the diagnostic criteria allow for an irritable mood to be present instead of depressed mood. Okay. Depressed children and adolescents commonly externalize the MDD by acting out toward authority figures, and by definition, MDD disrupts everyday functioning, including relationships, negative thoughts, nothing ever was are common. Treatment of MDD should include psychotherapy and antidepressants, SSRI, which are sertraline first line. It's not D. It was between D and F. Impulse control disorder is a diagnostic category involving difficulty to control impulses. It includes oppositional defiant disorder, conduct disorder, intermittent explosive disorder, kleptomania, pyromania. Oppositional defiant disorder manifests as a persistent pattern of angry mood, defiant behavior and vindictiveness that causes distress and impair functioning in the child or their caretakers. Angry mood, defiant behavior, and vindictiveness. This patient hostility is born out of her irritable and dysphoric mood state and is part of cluster of depressive symptoms, like MDD.
Next, very tough.
Yeah, that one was hard.
Which
Oh,
of the
you mean this question? Oh, you meant the other question or this one? Sorry. The
mm,
MDD, right?
yes, MDD.
Okay.
A 15-year-old boy is brought to the office because of 2-month history of increasingly frequent left lower thigh pain. The pain began after the injured his leg during a soccer game. He has no history of serious illness, takes no medication. Examination examination shows moderate tenderness of the lateral distal aspect of the femur. His serum alkaline phosphatase is 550. Serum lactase dehydrogenase is 316. X-ray of the thigh show which of the following? Okay, it is biopsy is that.
Okay. Is biopsy of the affected area. Osteosarcoma, most common primary bone malignancy in children, characterized by cells with enlarged nuclear and disorganized tissue structure, demonstrating area of osteoid production. Malignancy is locally destructive to bone and can erode through the cortex, resulting in periosteal reaction with elevation of the periosteum along with irregular rack borders and areas of disorganized osteogenesis as seen in this patient X-ray. Osteosarcoma typically occur on the long bones, often involving the tibia and femur. The initial presentation generally includes pain and swelling, though of fragility, fractures may be the declared in presentation. The sarcoma has high mortality and high rate of metastasis to the lung, even with adequate surgical resection, even when initial staging does not. Diagnosis involves imaging and tissue sampling with a biopsy of the affected area. For this patient, biopsy of the affected area should be completed in addition to MRI of the left femur for further characterization of the lesion. Next.
Okay, a previously healthy 18-month-old boy is brought to the emergency department because of 6-day history of fever, temperature, diarrhea, and pulse. 100 respiration 25 per minute, blood pressure 95 by 60. Examination show cracked red lips, primary erythema, and edema. Cervical lymph nodes are enlarged. There is pharyngeal erythema and bilateral conjunctivitis without injection and adjacent to the corneal lens. Recent, corneal lens. Rapid streptococcal testing is negative. Hematocrit 45%, leukocyte 10,500, segmented neutrophil 55, lymphocyte 40%, monocyte 5%, platelet count. ESR 35 in addition to IVIG, which of the following is the most appropriate? What is your diagnosis?
Kawasaki car.
Yes.
Mhm. Okay, so is oral high dose of aspirin. Kawasaki disease, also known as mucocutaneous lymph node syndrome, multisystem vasculitis, is in children characterized by fever for at least 5 days, polymorphous rash, bilateral non-exudative conjunctivitis, erythema affecting mucous membranes with dry cracked lips, lymphadenopathy, and erythema and edema of the hands and feet. The most common, it is the most common of the childhood vasculitis and is common cause of pediatric heart disease. Laboratories may show thrombocytosis, increased ESR in complete Kawasaki disease refers to presence of some but not all the diagnostic criteria, along with lab results showing thrombocytosis. Increased ESR, instead pyuria. Complication of Kawasaki includes coronary artery aneurysm, and if untreated, can lead to aneurysm, spastia, rupture, and MI. Therefore, children suspected with having Kawasaki require immediate evaluation with ECG and echo. Treatment and monitoring for progression of complications. Yes, treatment of Kawasaki involves high dose aspirin and IV immunoglobulins. This is the only widely accepted indication of aspirin use in febrile children because of the risk of Reye syndrome. Next.
A 35-year-old man who works as an orthopedic surgeon comes to the office because of one day history of severe low back pain after lifting heavy furniture. He has no history of serious illness, takes no medication to replace prescription for oxycodone. He is scheduled to give a lecture at a national meeting tomorrow. He is worried that he will be in too much pain and participate without medication. Vital signs are within normal limit. Examination shows no abnormality. Which of the following is the most appropriate next step in the management?
It's tricky.
Judge her, like be judgmental, then you can find the diagnosis.
You think you want to be judgmental in here? Okay, I
Yes,
guess.
be rude and judgmental.
Mm, okay.
Ready?
Mm, okay, let's check. I guess, yeah. Screen the patient for substance use disorder. Let me just see. Okay. This patient's subjective report of severe acute disabling pain is inconsistent with the absence of objective evidence of severe pain. Inconsistent with the absence of objective. Okay. Common cause of acute low back pain, such as muscle spasm, typically present with physical examination, such as positive straightness race testing. Additionally, pain is commonly associated with tachycardia hypertension, which is not seen in this patient. Okay. For patients seeking controlled substance like opioid and benzo who demonstrate inconsistent between subjective reports and objective evidence, the physician should screen the patient for substance use disorder. Substance use disorder is a clinical diagnosis made by the presence of personal, professional, social, emotional, behavioral, physical disturbance related to the use of substance or attempts to reduce intake. Symptoms may be classified as mild, moderate, or severe depending on the number of domains affected. It's not ordered during toxicology. Screening is helpful as an adjunctive assessment of substance use disorder. However, in toxicology, screening is not as specific for identifying negative psychosocial consequence of substance use and as screening for substance use disorder. Additionally, immediately proposing urine toxicology screen may interfere with the formation of therapeutic alliance more than directly asking the patient about the use patterns. It's not prescribed one tablet of oxycodone will be premature. First, the physician should screen the patient for substance use disorder. Additionally, a single tablet of oxycodone is unlikely to significantly influence acute pain if the patient is truly experiencing severe pain. Okay, next.
Okay. 49. Okay. A 37-year-old woman comes to the physician in January for immunization 6 weeks after 6 weeks before beginning a new job as a nurse aide in a skilled nursing facility. She has no history of serious illness, takes no medication. She has no known allergy. 4 years ago, she completed the hepatitis vaccine series and received tetanus booster. She lives with her husband and two healthy school-aged children. Examination shows no abnormality, which of the following is the most appropriate uh, to administer at the visit.
Mm, I don't know.
Ready?
Yes. It is inactivated influenza in January. Anyway, influenza virus vaccination is the most appropriate necessary management of this. Otherwise, healthy patient, the influenza vaccine comes in two forms. We already know that. In most cases, patients should receive the inactivated form of the vaccine. Each vaccine is designed each year to protect against and should be given yearly, usually at the beginning of the influenza flu, which is like September to February. Oh, okay. All patients over 6 months should receive the annual influenza vaccination, particularly those who work in the high risk settings such as hospital. Blah, blah. The only contraindication to receiving the intramuscular vaccine is a prior severe allergic reaction to the vaccine or its components. It's not Hep B booster is useful in preventing Hep B virus transmission in previously vaccinated patients who have low serum concentration of anti-Hep B surface antibody. Booster may also be given to patients with low Hep B surface antibody following an occupational exposure to Hep B virus in conjunction with Hep B immunoglobulin. This patient recently completed a vaccine series and has no occupational exposure, so booster is not recommended. It's not, where was that the other one? Pneumococcal 23 should be administered at adults beginning at 65. Um, yeah. Adults with history of cardiac or liver disease, diabetes, or alcohol use disorder may receive the 23 pneumococcal vaccine prior to 65. This patient does not have risk factors. Within, yeah, it's not necessary. Okay.
So inactivated influenza vaccine is given from since September through February.
Mm-hmm.
Okay. A 23-year-old man is brought to the emergency department after driving his automobile into the bridge embankment. Paramedics state that at scene his blood pressure is 100 by 80 millimeter mercury, that he was alert, uh, that the steering wheel was broken on examination. In the emergency department now is to porous cyanotic hypertension and has distended neck veins. Breath sounds are absent bilaterally. The trachea is in the midline. Which of the following is the most appropriate initial pharmacotherapy? Initial management.
Mm. Hypertension,
Distended neck vein,
distance, and
distant heart sound, but breath sound are absent bilaterally.
they didn't say anything about distant heart sounds though. They just said that. They say breath sounds are absent, and but the trachea is midline. So
Distant and like distant heart. Breath sound. Breaths. Distant heart sound. Heart sound means heart sound. Like the
okay,
first and the second heart sound. It is not the breath sound. Breath sound is the lung sound, isn't it?
yeah,
So, okay. You are thinking of tension pneumothorax. Possibility of having very high.
yeah, but it doesn't. But the trachea is midline. It either
But
B or C. How we
but
know?
in tension pneumothorax, there is distended neck vein.
Tension pneumothorax. There is distended neck. Yeah, I guess you can find that too. Okay, okay, yeah, it may be that. It may be that. Yeah, you're right. You can find that too. Pneumothorax results from air entering the intrapleural space from either anesthesia or internal wound. As the air accumulates within the space, the lung parenchyma becomes compressed, resulting in respiratory distress, decreased breath sounds, hyperresonance, percussion, and severe case tension on the mediastinal structures, impending venous return, resulting in hypertension. Signs of tension pneumothorax include tachycardia, hypotension, hypoxia, JVD, and tracheal deviation. However, in this patient with bilateral pneumothorax, tracheal deviation is not observed. Okay, because it's bilateral. Okay. In cases of acute tension pneumothorax, evacuating the accumulated air via needle decompression and aspiration permits expansion of the lungs. Blah, blah, blah. Needle decompression is followed by tube thoracostomy, which prevents reaccumulation and promotes repair of the pleural defect. In case of bilateral pneumothorax, respiratory failure will occur immediately, especially once closed pneumothoraxes are converted into open pneumothorax. Eliminating a pressure gradient across the thoracic wall requires immediate need for thoracostomy and negative pressure. Otherwise, ventilatory, I don't understand this. Pericardiocentesis will be appropriate for a patient with cardiac tamponade. Cardiac tamponade can result from penetrating chest wound and present with hypotension, distal heart sounds, and JVD. This patient with absent breath sounds more likely has tension in pneumothorax, thus pericardiocentesis would not be beneficial. Okay,
Okay, we are done.
okay. I mean, we're done with this block. We still have two blocks.
Yes.
Okay.